Hello, everybody. I'm Christina Traber, geriatric nurse practitioner with the Division of Geriatric Medicine at SLU. And today we will be talking a little bit about what exactly a Medicare wellness visit is and kind of how to go about building it. This project is supported by a HRSA grant for the Geriatric Workforce Enhancement Program. So today, the idea is at the end of the session, you will be able to describe the Medicare annual wellness visit and also possibly be able to incorporate that either into your clinic or in your nursing home work. And I have no relevant disclosures. So we know that the population is aging and the baby boomers are coming, or baby boomers are already here, really. Kind of an older slide. But a baby boomer turns 65 about every 8 seconds. And so looking at this, it's kind of population of 60 plus. So in let's say 1930, you don't have that many that were making it to 60. And as we've progressively gotten older and more advanced with technology and medicine, that has become more and more. But what I think is interesting is if you look kind of where we are or where we were in 2000, just over 40 million people over age of 60. And then you compare that to, where we will be in 2040, it's about 3 to 4 times, pretty soon that population will be hitting those targets. So we're obviously having a big influx of older people. And with that, it's a good time to tell you that even though we're having more and more older people coming into that geriatric population, our geriatrician number has pretty much not changed from 1988. So in 1988, we had about 7,000, just over 7,000 geriatricians. And in 2030, we're expected to have not much more than that. So that part has not changed. However, because we've gotten so many more population, you can see geriatricians per older adult, one for every 2,500 in 1988. And then in 2030, that's equivalent to about one for every 4,200. So quite a difference there. It's also the same for geropsych, so that's interesting as well. And okay, so Medicare annual wellness visits. So you turn 65 and they get a little card in the mail and it says you're eligible for an annual Medicare wellness visit. And they call the office and they say, I have no idea what this means. And for a while, I didn't either. So that's kind of why we're here. So once you turn 65, you can have what's called an initial preventative physical exam. So it's covered only once during that first 12 months of your enrollment, and the patient pays nothing. So, and we'll talk about what's kind of all included in that exam, but basically it's a review of their medical, their social, their health history, and preventative services. And then based on that, you're coming up with an individual kind of health plan for that patient. And then after they've had that initial preventative physical exam, sometime in that year that they turn 65, then every 12 months after that, they have another covered exam, which is what's actually called the annual wellness visit. And so again, this visit is developed to update that personalized preventative plan that you made and also also to perform health risk assessment every year to see what's changed and what else would need to be updated in that plan. Again, the patient pays nothing for this visit. Okay, this is different than when you go to your doctor when you're younger, you go at 40 for your routine physical exam. Medicare does not have anything like that that's covered. So if you make an appointment to have a routine physical at the age of 66, it's not covered by Medicare as a free visit, which is why it's important to understand. So unless it's a visit that is either the medical wellness visit for the 12 months or something that's specific to a diagnosis. So you have diabetes and you're going every 6 months to see your endocrinologist, that's covered because it's specific to a diagnosis. But as far as just doing a routine physical exam, Medicare does not have that. So again, that would not be covered by Medicare. And so the patient would have to pay for that out of pocket. And so again, kind of just a different chart, but again, this yearly idea of a physical is not covered by Medicare Part B. And so all of that idea is kind of thrown out. And instead, you get this initial or welcome to Medicare exam that you get once, and you review your medical and social history, and you go through kind of a shorter version of a physical review. Typically, we do your vitals and we'll check your vision and do your BMI, and we do some screening, do a lot of screening. And then most of it's spent on education and counseling and referrals for prevention services and coming up with this personal plan. So the annual wellness exam is then what it's called that you can have every 12 months after that. And in that area, you're going to review medical and social history. You're going to again do the shorter version of the vitals and prepare that wellness plan. And then also included in that, and we'll talk about it, is you can do advanced care planning as part of that as well. Again, just another way. So annual physical exam is when you would get blood work and lab tests and all those things previously. That's not what an annual medical wellness visit is. But with that, you don't have to have a copayment. So, okay. So in the Medicare annual wellness visit, there are kind of three components that are covered. So again, a health risk assessment. So typically we'll talk about this a little bit more later. It is a self-health risk assessment. So they are asked all sorts of things on safety and tobacco use and drinking and all of those things, seatbelt use, that they kind of do a self-health risk assessment. And then after all that data is collected, then a provider, either an advanced practice nurse or a physician, would do a provider consultation where they reviewed all that information and they decided what was important. And then with that, with the patient, then you would come up with a personalized prevention plan. And for billing purposes, that initial one gives you a little bit more, again, only once per lifetime, but you get about $172 average reimbursement. And then every subsequent one, you would get around a little over $100. And that would be payable again every 12 calendar months is the way that they do it. Okay, so necessary components, and it's a lot. So again, this health risk assessment. So typically this is given to the patient either, we give ours through Epic. Prior to them coming, they can fill it all in, and so it's already done, or they can do it on a laptop or an iPad before the provider sees them. But at minimum, it has demographic data, it has this health status self-assessment, and that looks at psychosocial risk factors such as depression, stress, anger, loneliness, pain, and fatigue. It looks at behavioral risk factors, including, but not limited to, tobacco, physical activity, nutrition, oral health, alcohol, sexual health, motor vehicle use. So like I said, seatbelt use, and then home safety. It looks at activities of daily living, which includes dressing, feeding, toileting, grooming, ambulation. It looks at risk of falls. It looks at your IADLs, your instrumental ADLs, which includes using the phone, doing your laundry, mode of transportation, shopping, etc. Okay, so that's what they're going to perform kind of on their own. And then at a minimum, we're going to establish their medical and family history. We're going to also go through all current lists of the providers. So who they see for vision, dental, podiatry, cardiology, everyone they see outside of you needs to be written down here, including behavioral health. And then we're going to measure those few things. Like I said, it's not really a full exam, but we are going to get height, weight, and BMI. Typically, we still get blood pressure. And then other routine measurements deemed necessary. So anything else that we decide might be necessary. If everyone had a history of heart issues and AFib, we might get a heart rate as well. Cognitive impairment. Everyone has to have a cognitive screen. At SLU, we of course use the RGA and we use the rapid cognitive screen, which I'll go through a little bit later. And then we're going to review their potential depression risk factors. We're also going to go through their functional ability and the level of safety. Are they a fall risk? Do they have hearing impairment? What is their home environment? How many steps do they have? Do they have a shower grab bar? Do they have a commode? All of those things kind of fall in there. We're going to establish an appropriate screening schedule. So based on the preventative health task force, kind of all of the immunization schedule and preventative task Force things, we'll go through that later. Health status and screening history. Again, depression and substance abuse is on here quite a few times. So they definitely want to make sure that we get that. And then we're going to provide the patient's personalized health advice and appropriate referrals. So once we have all that information, we're going to pull it together and we're going to decide what referrals they might need educationally, counseling, what or whatnot. So community-based lifestyle interventions, including fall prevention, nutrition, physical activity, tobacco use, weight loss, cognition. And then, like I said, there is a component as well that you can include advanced care planning. It's actually billed separately, but together. And if you do it the same day as you do your annual wellness visit, then Medicare waives the copayment. So it is a free service as well, but only if you bill it together on the same day. And I think we talked about that again in a minute. But again, going through what if they have any advanced directives, what future care decisions they might want, who their POA is, who they might want to have be their POA if they don't have one, all of those things. Oops. Okay. So to the appointment, the patients are asked to bring all the information, all of their family history, their full medication list, all of their providers, their DME supplies, their immunization record, and their screening test. Sometimes you are the primary care physician, so you might have all of this information. Other times, there are groups that do just they're the annual wellness group, and they're doing an entire system's annual wellness visit. So they might not be your primary. So that's why it's important if it's not already in the medical record. So the assessment, so all of the things that we talked about before, the provider can be done by anyone. So not just the physician or the advanced provider. So typically what happens is the patient comes in with their self-risk assessment. They're brought back by either by the medical assistant, and the medical assistant will go through all of the screenings, do the height, weight, do the functional status exams, do the safety screens. They have a whole kind of template that they do. And then that's what's the basis for the recommendations. Then the advanced practice nurse or the physician will come in and make. So we use the SLU rapid geriatric assessment, like I said, for a lot of our screening. The Medicare does not specify specifically what tool you have to use. You just have to have a cognitive screen, and you have to have some other screens. And so this is what we use. So we know that the rapid geriatric assessment is an early detection of common geriatric problems. We find it to be a brief, reliable, and validated tool, and it tracks changes over time. So not just in annual wellness visits, but we also do it in our clinic patients on a rotating basis as well. And it includes all the elements basically required for the annual wellness visit. So again, this is the rapid geriatric assessment. It includes a frailty questionnaire. It includes a questionnaire for sarcopenia or muscle loss. It includes a nutrition, and it also includes the cognitive screen, which is based off the St. Louis University mental status exam or the SLUMS. It does ask other questions as well, and it asks if you have an advanced directive. So this is the frailty score. So again, anything 3 or greater would indicate frailty. This is the SARC-F, or a screen for sarcopenia, so how much muscle mass they have, risk for falls, and a score of anything more than 4 is considered positive. There's also a nutrition SNAC, Simplified Nutrition Assessment Questionnaire, and a score of anything less than 15 is highly predicted of weight loss over the subsequent 6 months. And then, like I said, the rapid cognitive assessment is based off the SLUMS, a shorter validated version. Basically, it's the 5 words, the clock, and then the story with 1 question at the end. And here's the scoring, kind of 8 to 10 is normal, 6 to 7 mild, and less than 5 or less would be considered dementia. And then again, like I said, we ask for advanced directives. We do give the websites in case someone needs to still do that. Depression screen, we use the PHQ-2, pretty much on all of our patients regardless. So sticking with that unless we feel like we need to do more. Additional safety stuff, we ask if they smoke, how many alcohol beverages they have a week, if they feel safe at home, if they're still participating in sex, have they had any accidents or gotten lost while they were driving. And then here's all kind of the health preventative stuff. So we're going to review all of this and kind of see where we are based on their age, what they would be appropriate for. Again, we're using the United States Task Force to kind of lead that, to let us know what people should be doing. Colorectal screening until the age of 75 is the typical recommendation. Unless someone has family history. If someone's 75 and pretty healthy and has a big family history, we would still recommend. Mammograms until the age of 75, bone density. They need to have a low dose CT chest for lung cancer if they have a history. AAA screening, one time only. Prostate, we don't really do, recommended against. And then hearing and vision. And we also go through all the immunizations with them as well. Okay, so once all of that's collected and answered, then this is the only part, then the provider consultation and the personal advice section that has to be done by an advanced practitioner or a physician. And so at that point, we're going to review all the data. We're going to create a risk factor list. Are they at risk for depression, social isolation, colon cancer from family history? And we're going to create a screening schedule, and we're going to give them a personalized health advice and prevention plan. And we may or may not also do advanced directive discussion if necessary. You can do a focus exam, but only as necessary. So typically it's not much of a physical. It's more of a discussion. So based on the risk factors identified, this is when we're going to give them a written plan. It's age appropriate with screenings and referrals. It provides written recommendations back to the PCP. So again, if you're not the patient's PCP and you're just doing it as a consult, you would give the primary care physician or provider your recommendations from the annual wellness visit. And you would also provide the patient with educational handouts. Okay. So these are kind of based on our rapid geriatric assessment. We kind of already have these information sheets made up for each of the 4 screenings. So I like to use these. I find them very helpful and the patients really like them. So this is the one, if someone were to test positive on the frail, I would give them this one for frailty information sheet. And it just talks about what it is, what it indicates, and ways to prevent or treat it. In frailty's case, it would be aerobic and resistant exercise, more protein, vitamin D, and a reduction in meds. And then it gives kind of a little seat to chair 5 times, or weights that they could use, or things that they could easily use at home for something to do. Sarcopenia, kind of similar. Again, we're trying to get them to be more resistant. Training exercises, so a few more of those kind of interventions there. Brain health, so again, up here we can write down kind of what the rapid cognitive screen was so that they know what it is. This one's for more mild impairment, but things that they can do so they can use their brain, use it, don't lose it, do more brain games, eat a Mediterranean diet, have your doctor check for treatable conditions, stay active. Again, so there are a number of treatable causes of memory, including depression, sleep apnea, hypothyroid, and B12. So just information for them to take back to their primary, or if you are their primary, then this is when you would kind of decide what you're going to do with these screening tests. So again, excluding treatable causes for dementia, Mediterranean diet and olive oil have been shown to be effective, as well as exercise. Socialization, if they're lonely, tend to be more depressed, tend to affect your memory. We often refer people to Alzheimer's Association. We often refer people to cognitive stimulation therapy, Circle of Friends, other programs like that. They might need a safe return bracelet or a safe button on that they wear just in case they fall. We often discuss a lot of driving with people and safety there. We do also discuss gun safety if they indicate that they have firearms in the home. And so after they've kind of gotten all their information and you have their plan and you have their immunization plan that you're going to go with, then you can also talk about advanced care planning. Like I said, that can be part of the annual wellness visit. It is optional. It is an additional billing CPT code. But like I said, if you do it the same day as the wellness visit, then the deductible and coinsurance fees will be waived. So it is a free service at that point. Again, provided on the same day by the same provider and bill with the modifier on the, and that's kind of how that works. So we have an Epic template that kind of pulls all of this stuff in, like I said. So drops in all of their medical history, all of their vitals. It picks up the RGA with all of those things. It does the PHQ-2, and then our MAs kind of fill in all these other things with us. And then when we come in, then we review all that and decide what the plan needs to be. So kind of typically, our template says a care plan for the patient has been established and reviewed with the patient, and then see patient instruction notes for personalized prevention. And so these are the kinds of things that I put in my prevention plan. It might say, they screen positive or negative for all of those screens. And if they score positive for frailty, it will say that I instructed them to do exercise, and we're going to do 5 chair squats a day along with use 2-pound hand weights. Patient is falling or is high risk for falls, they have polypharmacy, or they're felt to be unsafe at home. All of these things are things that we're going to put in our plan, and then recommendations for those things. If they're driving and we're worried about their driving, we could send them to the driving evaluation. Updates on immunizations, like I said, referrals to Alzheimer's Association, referrals to counseling, all of those things would be put in here. If it's polypharmacy, my recommendation might be that we're going to stop all of these medications or make medication changes. Again, recommendations also could include further medical workups. We might want to do a sleep study if they have dementia. We're concerned about that. Might include lab tests. Again, suggestions for medication adjustments, referrals, so social services, therapy, home health, dietitian, any of the specialists. And then health maintenance for the age-appropriate screenings and vaccinations. And again, just more driving evaluation, safety proof, smoking cessation, all these things I kind of already said. Educational handouts are provided to them. And so again, 12 calendar months, they would come and do this again. We would look at it again. We would update it, decide if anything is different or changed, or if anything needs to be taken off or added. So these are the coding. Again, annual wellness visit. Initially, just one time only, and then subsequently 12 months after. And then again, you can add this advanced care planning code on the same day, and that's based on time. So first 30 minutes as opposed to each additional 30 minutes is a different code. So I already said that stuff is all in Epic. We also do this in the long-term care setting. So we have kind of a paper that we've been doing. We need to try to see if we can get this uploaded into hopefully electronic as nursing homes go more electronic as things move on. But again, kind of all the same things, but in a paper format. We're doing vitals, we're doing vaccinations, we're doing active diseases, past medical history. Here's our little self-assessment. So sometimes able to respond, sometimes you're doing it on a patient that's 70 and has dementia or is nonverbal. So that would be a no. Other medical providers, if they've been in the hospital, all the devices and special equipment they have. We're again going to use the RGA, but we do have a little bit different of a frail scale for the nursing home. So that one is listed here. It takes into account whether or not they use assisted devices, whether or not they're incontinence. So a couple of different things there. Again, these are all the screenings we possibly could do. Looking at risk assessments, are they a fall risk? Do they have psychosocial risk? Are they behavioral risk? Are they on opioids? And then again, assessment, like we have done this annual wellness. These are the findings. They are either cognitively intact or impaired, or frail or disabled or falling. And then these are our recommendations. Are we going to update vaccines? Do they need therapy or CST? Do they need polypharmacy review? Advanced directed discussion, was that done? Do we need to refer to anyone? And again, like these are our primary care patients. We're seeing them more often than you would see clinic patients, so we're seeing them pretty often. However, we still do these in the nursing home on a yearly basis because it helps us review these things that often we don't think about when we're seeing them for their kind of routine visit. Um, Again, so it identifies nursing home residents who are at high risk for rapid deterioration. So if you see someone and you just haven't realized how much weight they've lost over the last year because you're seeing them more often, it might indicate that maybe someone would be hospice appropriate or something like that. And so that's really where we find it most helpful. So recognizing treatable conditions, um, help guide advanced care planning, help identify those who may be hospice appropriate, and also updating immunizations, ancillary doctors, and if someone might need another referral to PT or OT. Okay, any questions can be sent to me. Thank you very much.